Also comes with anxiety. Anxiety can also be its own issue. Anxiety disorders, we most commonly think of obsessive compulsive disorder. We all say, oh, we're OCD. Well, we're not. You're not, trust me, unless you can't leave your house until noon because you had to lock the door, whatever your ritual is. Now, bipolar, or not bipolar, OCD tendencies, yes, I got to have this, this, that, blah, blah. Well, lots of things to treat anxiety disorders. Most anxiety is related to depression. So, an anxiety disorder can be treated with an antidepressant. Prozac is very effective for the treatment of anxiety um, and is actually one of the mainstays for treatments of people with true obsessive compulsive disorder. Also, for anxiety are benzodiazepines, okay? Valium, Ativan, Klonopin, Xanax, all right? We have to be careful with these. They have an addiction profile, okay? Um, but they also have their place. Just because someone's taking that doesn't mean that, oh, yeah, that's the kind of person they are. No, they may actually need it because they could be, just in a miserable, horrible state without it, okay? When you start prescribing benzodiazepines orally, ease into it, okay? Um, Also, for the quiz and for um, board examination purposes, remember that romazicon or flumazenil is the reversal agent for benzodiazepine overdose. Um, Other uses for benzodiazepines also are and anxiolytics. If you got a patient in the office and you're about to perform a procedure and they're nervous as all get out, give them a Valium. It'll be okay. But people with chronic anxiety really should be on an anxiolytic if an antidepressant isn't quite cutting it. Okay, so let's say, man, I got these really cool, the little slots in the blinds on my window, kind of avatar looking thing. Anyways, um, crap. What was I talking about? Benzodiazepines. So, quiz question. This person's been treating for anxiety. They're on Prozac. They're doing well. But the anxiety is really starting to creep in. They're having some more stress in their life. I mean, they've got a legitimate reason to have it. What might we add to their treatment? And it would be, like Klonopin TID or Xanax Q6 as needed, something like that. Okay, you'll recognize it as benzodiazepine. All right. What else does this? That's about all there is in the psychiatric chapter that I'm going to quiz you over. Um, that's the one chapter of the book so far that I really don't like how it's laid out. Okay, so housekeeping. Last quiz, everybody did wonderful on it. I appreciate everybody's patience. This is the first semester for me to teach this course, so the way I originally envisioned it going and the way it has gone are two different, well, not two different things, but it's a lot different than what I thought, which is to be expected. However, I hope that the course is still accommodating you. Um, I, I spoke to a professor at a competing university, and they were talking about their program. This professor teaches pharmacology, such as I do, and I felt there was a lot of busy work involved. So I hope that you're learning from this. I haven't had anybody say, "Oh, the course isn't hard enough." Remember, it doesn't matter if you're reading this on your own at home, watching my lectures, or if you have to come to a classroom every day and listen to me. You're only going to learn as much as you want to. Okay, what you read, how much you repeat your studies, and those sorts of things. So I hope you're coming out of this with something. You will be prepared for your board's examination. Do not worry. You're going to study quite a bit when it comes down to that. I know you will. Anyways, everybody's doing well in the course. I think there's probably discussion board number 3. It was probably supposed to be posted last week. Actually, what I'm going to do is toss that up next week after this quiz. We'll open the quiz. I'll have the quiz posted by Friday evening, um, and I know I will because modern gun season opens Saturday morning, and I will be in the deer blind. But I'll have my phone if you got any questions or problems with your quiz. It won't be that bad. It'll be on silent, so if I don't answer immediately, you know where I am. Anyways, I'll have the quiz posted Friday. I'll leave it open for a week. Again, because it's going to have far more chapters on it, like the last one. I'm going to give you 4 hours to take it. Uh, I'll just hit through each chapter, and I'm going to give you the meat and potatoes that we've talked about, things that are most significant for you. Nothing tricky. Some of you had some questions about the last quiz. There was one. Oh man. There's one question. Oh, okay. Here's what it was. I really wanted everyone to see where I was going with this, because this is really going to happen to you. The patient with atrial fibrillation and a GI bleed. Okay, so it's going to happen. Now there are good medications out there that help reduce it. Eliquis I find is the best. I like it. It's just expensive. So the patient, I believe in the question was they presented to your office. They were an AFib. It was an uncontrolled rate, um, and they were anemic, or I think they were anemic. They were Coumadin toxic. So I've been in that situation many a times. What do you do with the patient who's Coumadin toxic and in rapid atrial fibrillation? Well, get them to the emergency was the right answer. Emergency room was the right answer, and I'll tell you why. Um, there are multiple factors that you're going to treat. There's not just one thing. Number one, what caused the toxicity and what caused the atrial fibrillation to become rapid? This patient is on Coumadins for atrial fibrillation, so they've had it for some time. Um, they haven't presented with uncontrolled atrial fibrillation previously, so we have good reason to suspect that it's been managed, whether their rate's been controlled or whether they've been in a sinus rhythm. Remember this for patho, the number one goal for atrial fibrillation is rate control, okay? Because that's where the risk of developing a thrombus in the left atrial appendage comes is from increased rate. And I'm talking things like 150 or greater, okay? Now, we don't want people hanging out in the 120s, 130s, but that's a lot less. That's still a stable tachycardia. About 150 and up is an unstable tachycardia. So, patient is an RVR and they've got a toxic Coumadin level. So why would we not give them vitamin K? Very good question. You could. Is the patient bleeding? I don't know. I can't remember what I put in the question. And let's make the case even more complex. Let's say they're complaining of dark stools, and you at least did a hemoccult, and it is positive. So they got a GI bleed, they're Coumadin toxic, and they're an RVR. So what the heck are we going to do? Get them to the ER. We're not going to give vitamin K. Number one, we don't want to induce a hypercoagulopathy while they're in an uncontrolled rate. We have about a 48-hour window when atrial fibrillation is uncontrolled and a patient is not anticoagulated that before a left atrial thrombus will start to develop. So we don't want to make the circumstances better for that to happen, because what if we can't control the rate? What if this is one of these individuals where I've got them on cardizem, that didn't work, I've tried digoxin, I've tried amiodarone, whatever it is not working. Maybe their blood loss is significant enough that that's causing the tachycardia. And that's why my medications aren't working. So I don't want their blood to thicken up enough where they can start developing a thrombus and then have a clot. Now, the other part of that is, if we can treat, how high is the INR? I don't think I specified in the question, or if I did. It takes a lot for me to give vitamin K. I'm talking like they need to go to surgery, I'll give it, okay? Coumadin toxicity will resolve itself very easily by simply holding Coumadin. But in this situation, once again, it's a no-win situation that I gave you. And I'm in it all the time. And what you do is you start looking for causes. You want to treat what's causing this. And then how bad is this bleed? Is it stable? Can I just give blood and wait till we get the heart rate managed and start getting them off? Can I substitute an anticoagulant? It's not an easy question to answer at all. So that's why the answer was get them to the emergency room. Okay. Um, so when faced with a situation that is clearly has the potential to become out of control. It has nothing to do with your ability or expertise or lack of knowledge or competence. It's got nothing to do with that. There's always a time to know when this is escalating beyond what I'm going to be able to manage here. So for the patient's sake, let me get them somewhere else. And that's one of those things. Okay, I've babbled on plenty, so we've got one more. We'll do a discussion board next week. I'll leave the test open for a week. I'll do a discussion board next week. The material that will start next week will be the material for the last quiz. So there'll only be 7 quizzes instead of 8 because I've got to compact it down. And I think we'll have Thanksgiving break during then. I've got to ask when the actual last day of class is. I've not been privy to that information yet. And I'll try to look at when all the other, who else is doing a final exam or something like that. I don't want to stack them on top of you. We'll coordinate that so that you are able to take it at a good, convenient time. Grades are looking great. I promise I will have that all straightened out soon. The grade book is one of the great mysteries of the world to me. But everybody's doing great. Not a soul is failing the class. And once, hold on just a second.